Good morning to all. I am Dr. Karthik Natarajan, Associate Professor of Cardiology from UNMICRC Institute of Cardiology and Research Center. I'll be talking today about the planning and technical aspects of Evar. So we'll go through the introduction, the planning, the technical aspects, stent graft types, deployment techniques, intra-procedural imaging, the post-procedure care, the complications and challenges, and the conclusion. So this is the aortic aneurysm classification that we are all aware of. You can have an ascending aortic aneurysm, you can have an arch aneurysm, you can have the various kinds of Crawford and Safi thoracoabdominal aneurysm classification right from type 1 to type 5 depending upon the extent of involvement, and you can have an abdominal aortic aneurysm which can be defined in relation to the renal arteries, whether it be an infrarenal, juxtarenal, pararenal or suprarenal aneurysms. So abdominal aortic aneurysm represent potentially life-threatening scenario affecting important segment of the aging population. Surgical resection and interposition of abdominal aortic prosthesis either by a Dacron or Gore-Tex have long been considered the standard treatment. But in the recent years, or I would say since quite some time, endovascular strategies have evolved and are the standard of care for patients who are considered too sick or old for open surgery. Stent graft bridges the region of the aneurysm, excluding it from the circulation while allowing aortic blood flow to continue distally. So over a period of time, there is no blood flow in the false lumen or in the aneurysm sac, and that results in thrombosis of the aneurysm. Parodi and colleagues reported the first endovascular repair of the abdominal aortic aneurysm in humans using graft fashioned from vascular grafts and expandable stents, and in India, it was first performed in 1997. The main advantages over an open repair are avoidance of long incisions in the thorax or abdomen, no cross clamping of the aorta, less blood loss, lower incidence of visceral, renal and spinal cord ischemia, less perioperative mortality and earlier return to normal activity. And it is performed by inserting graft components folded and compressed within a delivery sheath through the lumen of an access vessel, usually the common femoral artery, although there may be various other approaches which can be used in case the common femoral is inaccessible. And upon deployment, the endograft expands, contracting the vessel wall proximally and distally to exclude the aortic aneurysm sac from the aortic blood flow and pressure. So what are the indications? Now the indications of abdominal aortic aneurysm interventions are varied. So the most important is symptomatic, either a tenderness or abdominal or back pain, evidence for embolization or rupture, aneurysm sac size which is more than 5.5 centimeters, increase in size by 1 centimeter per year, and in women with smaller native vessels, size that represents aneurysmal disease may be less than 5 to 5.5 centimeters. In a general tone, it may be said that anything which is say more than the two times the size of the aortic diameter can be considered an aortic aneurysm and can be considered for intervention if it is symptomatic. So the patient selection is, you have to assess the body habitus and gender as smaller size and female gender associated with a higher risk of procedure abortion, and assess the comorbidities including the cardiac, pulmonary and renal conditions, and risk stratification analysis indicates the survival for those at low to minimal risk is excellent over 10 years. So when we are planning any abdominal aortic aneurysm Evar, then we need to know the anatomy very clearly. What are the various vessels which come right from the celiac to the superior mesenteric, to the inferior mesenteric and finally the renals, and all the lumbar and the inferior phrenic arteries, because each of these accessory vessels could be a potential reason for endoleaks post Evar stent deployment. So abdominal aorta, as we know, is the most common site of an arterial aneurysm and is defined as a focal dilation which is exceeding 1.5 times the normal diameter, and the normal diameter is approximately around 2, although this may again vary, and a diameter which is greater than 3 may be considered theoretically as an aneurysm. And approximately 5% will involve the renal or the visceral arteries, and up to 40% of the abdominal aortic aneurysms may be associated with iliac artery aneurysms. And majority of endovascular repairs are performed on aneurysms affecting the infrarenal aorta and the iliac arteries, although those who are as expert centers with the experience of doing fenestrations, they can also extend the stent graft suprarenally. So when you are planning any Evar, the most important investigation after you rule out a high surgical risk is to go for a CT. I think a CT is the standard a CT angiography with 3D reconstruction with a calibrated catheter is preferred, and 2D CT will the aortic diameter will overestimate if the aorta is angulated, and if the long axis is not perpendicular to the imaging plane. So you don't generally use a DSA or MR angio. It can be done, but there are issues. But the most important assessment in CT is by CT. And if you look at the CT, then what do you define? You look at the proximal neck, the diameter, the length, the angle, and the presence of or absence of thrombus, the distal landing zone, the diameter and the length, the iliac arteries, diameter and occlusive disease, and the access site vessels, diameter and the occlusive disease. So what is the aortic neck? So the aortic diameter at the lowest renal artery is referred to as the aortic neck, and the required endograft diameter has to be 15 to 20% more of the measured aortic neck diameter. So you require that the aortic, the sizing of the Evar graft, the proximal end has to be around 20% oversized as compared to the aortic neck diameter, and oversizing provides sufficient radial force to prevent device migration. Devices up to 36 millimeter diameter are available, but you cannot oversize it to more than 20%, more than 30%, because it can lead to kinking of the device, which can form a nidus for thrombus formation or endoleak. And undersizing is always a problem because it can increase the risk of type 1 or type 2 endoleak and give rise to an inadequate seal. So this is the the definition of a conical neck. So in Evar, the most difficult anatomies are associated with the conical neck. So when do you call it as a conical neck? When the diameter of the aorta 15 millimeter below the lowest renal artery is 10 times larger than the diameter of the aorta at the lowest renal artery. So if you look at this, the figure on the right, you can see that the D3 is more than 10 times of D1. So if you have this conical neck, then there is a problem, because there can be a high chance of rejection. You have to gradually oversize. Suprarenal fixation is a problem. Then balloon expandable stent and fenestrated or branch endograft. So you can either oversize, which is not a great idea if you have a very short neck, because as I already told you, oversizing can give rise to kinking or thrombosis and endoleak. Suprarenal fixation is an idea, it's a good idea where it is done. The best idea would be to go for either a fenestrated or branched endograft or a chimney procedure. So what is the aortic neck length? So distance from the lowest renal artery to the origin of the aneurysm. So this should be at least 10 to 15 millimeters to provide an adequate proximal landing zone for endograft fixation. Now you should remember that these endografts, they don't have active fixators. They don't have enough radial strength. So you require a good enough seal both at the proximal and as well as the distal end to have to avoid the blood flow into the false lumen on the aneurysm sac. So you require at least a 15 millimeters landing zone proximally as well as distally to achieve adequate seal. The neck angulation. Now the angle which is formed by the points connecting the lowest renal artery, the origin of the aneurysm, and the aortic bifurcation is referred to as the neck angulation. Referred to as the neck angulation. Ideally, the aortic neck angle should be less than 60 degree, and angles that are greater lead to difficulties in implantation, kinking, endoleak, and potential for distal device migration. You need to look at the iliac arteries. They should not have any significant stenosis, mural thrombus, calcification, or tortuosity. As I said, 40% of the abdominal aortic aneurysms have associated iliac artery aneurysms also. So in some cases, you may need to extend or add an extra iliac limb for extension of the endograft. And CIA is the preferred distal attachment site. And if you use the EIA for distal fixation, then you need to usually embolize the hypogastric artery to prevent back bleeding into the aneurysm sac, which can be a common source of endoleak. The EIA diameter of at least 7 mm is required to allow safe passage of the endograft delivery system, and a CIA diameter which is between 8 to 22 millimeter, and the length of the normal diameter into which the limbs are endographed and which will be implanted should be at least 15 to 20 millimeters to achieve an adequate seal. And diffuse narrowing or significant calcification and iliac conduit has to be done, or you may need to go for an alternative access like an axillary access or sometimes even a transcaval access. Then renal artery anomalies may be there in 30% of the patients, and you need to exclude the renal axillary vessel by endograft can lead to partial renal infarction. So in those cases where you have a conical neck or the renal artery is very close to the origin of the aneurysms, the best way to go is for either a chimney or a fenestration. The inferior mesenteric artery may also arise from the aneurysm, again, which may need to be coiled to prevent bleeding into the aneurysm sac. So this is what is ideal for an Evar. You can see that the aortic neck should be more than 15 millimeters. The ideally more than 15 millimeters, although some of the devices claim that they can, even with an aortic millimeter of more than 10 or just more than 10, you can actually implant the device. The diameter should be less than 28 millimeters. The aortic neck angulation should be less than 60 degrees. The iliac diameter should be more than 7 millimeters, less than 15 millimeters, with minimal to moderate tortuosity. No mural thrombus at the attachment site. Minimal calcification. No associated mesenteric occlusive disease. So this is how your generally the pattern of CT reporting is done. You have a 3D reconstruction and you have the various diameters both in the the longitudinal axis as well as in the coronal sections. They give you the diameter, they give you the calcification, they give you the aortic bifurcation also, because sometimes the aortic bifurcation may be narrow. So when you use a bifurcated limb graft, then the aortic bifurcation, if it is narrow, then you may the contralateral limb may not open up and it may be very difficult to cannulate the contralateral limb. So in those cases, you need to put in 2 extra balloon expandable stents to actually keep the aortic bifurcation patent. So this is how a standard reporting of the Evar planning is done by a CT, and there are various grafts which can be used. Now I'll not go into the detail, so you can find that there are a lot of companies which make various customized grafts. So this is the Cook, which makes you a custom. It is a graft which takes around a month to get prepared. So you get the CT done and you have a customized graft according to the patient's, patient suiting the patient. And also you have fenestrated grafts suiting which orient themselves to the various arteries. And as I said, there is importance of oversizing. You need to oversize by not more than 20%, and it should be around 10 to 20% oversizing. These are the suboptimal necks, as I said, for Evar. You can see that the lowest renal artery, and as you go down, there is an increase in the diameter. So these are the suboptimal necks for Evar. What are the contraindications for an Evar? Short proximal neck, thrombus in the proximal landing zone, conical proximal neck, more than 120 degree angulation of a proximal neck, critical IMA, significant ilio-occlusive disease, and tortuosity of the iliac vessels. So endograft is a fabric covered stent. There are significant variations in the endovascular graft design. 3 types of components are common to all: delivery system, main body device, and the extensions. So the delivery system is delivered through the femoral artery either by percutaneous means or by direct surgical cut down. For an abdominal aortic aneurysm, usually the size of the sheath is around 14 to 18 French. So it can be done with 2 proglides which are pre-placed, and you can even use an angio seal at the end if there is an inadequate seal. For the TEVAR devices, generally you require an aortic cut down. If the femoral artery is too small to accommodate the delivery system, access can be obtained by a synthetic graft to the iliac artery through a lateroperitoneal low abdominal incision. And as I said, nowadays you have a transaxillary access, you have a transcaval access which can be used if the iliac and the common femoral are inaccessible. The size of the delivery system varies depending upon the device diameter. The main device, a body device, in case of an abdominal aortic aneurysm, is usually bifurcated unless you have a very small and short aneurysm with a very good landing zone distal to the bifurcation, in which you use an aortic extension. Otherwise, the maiden body device is usually bifurcated, and the endovascular grafts rely primarily upon the outward tension in the proximal graft to maintain the position of the graft. And fixation systems can also be used, which can include barbs or suprarenal uncovered extensions. Then endograft extensions may be required to place adjunctive grafts which cover the iliac arteries, and the iliac limbs may vary in length depending upon whether a graft is a 2-component or 3-component graft. 2-component grafts have 1 short and 1 long iliac limb, and 3-component devices have 2 short limbs. So these are the various devices which are available. You have the Aptus, you have the Cook Medical, the Cordis, you have devices from Medtronic, you have the Gore and Associates device, you have Trivascular and Vascutech. But the device which I will be discussing is the Medtronic device, which is commonly used at our setup. So you have that the various the devices available are more or less same. Some of them may have Dacron, some of which have Teflon and PTFE. But generally, some of them, like the Zenith, has a hook or barb as a fixation mechanism, but more or less the mechanism of the grafts remains the same. The Medtronic has the Endurance stent graft system. It's a modular bifurcated device which is composed of a multifilament polyester fabric with an extension self-expanding support structure of M-shaped electropolished nitinol stents, and proximally it has a suprarenal nitinol stent with anchoring pins for suprarenal fixation, and the graft design is intended to treat aneurysms with a more challenging anatomy. So the Medtronic company claims that the Endurant can be used with even an aortic neck length of around 10 millimeters. Just at 10 millimeters you can have a good fixation if you place the stent below the renals. So this is the various kinds of devices. So you have a bifurcated device, you have the aortic extensions, and you have the various markers which will give you an idea of the orientation of the ipsilateral and the contralateral limb. This is the aortic delivery system in which you have the various systems. This is the back end wheel, you have the rear handle, you have the back end screw gear, the external slider, you have the front grip, and you have this tip for the tip capture. And this is the iliac delivery system, again with the rear handle, the screw gear, the external slider, the front grip, then the tape and the taper of the tip. And this is the general way of reporting any Evar before it's done. You need to plan, you need to look at the diameters and the possible graft that you will be using. And this is the various diameters that you need to know before planning the graft. As I said, sometimes you can have a narrowed aortic bifurcation. So you need to make sure that the contralateral limb does not open up at the aortic bifurcation. Or in that cases, the contralateral limb may not open up and it may be impossible to cannulate this graft. So the aortic bifurcation has to be wide open so as to cannulate this graft. The choice of graft, there is no clear advantage of one over the other. The choice is dependent on multiple factors including patient anatomy, operator preference and cost. Bifurcated grafts are most often chosen but are not appropriate for patients with unilateral severe iliac stenosis or occlusion. If there is unilateral aortic stenosis, iliac stenosis, then you may either use a non-bifurcated graft or you may use an aorto-uniiliac device and go for a fem-fem bypass for the opposite side. The preparation, we can give antibiotic prophylaxis and adequately hydrate the patient, and antithrombotic therapy may be given, although it's not a usual norm. You gain vascular access, you place the arterial guide wires and sheaths, imaging to confirm the aorto-iliac anatomy, main body deployment, gate cannulation, iliac limb deployment, graft ballooning and completion of the imaging. So anesthesia, it can be done at a GA or local now. As in when we are increasing our exposure, now we have started doing it with 2 broglides pre-placed, so that procedure is under local anesthesia. You obtain the vascular access under ultrasound guidance. Also, if you are using a surgical cut down, you can use a surgical cut down. Small caliber vessels, as I said, you may need to use an alternative access or you may use an iliac conduit. Then you cross the aneurysm and then you deploy the graft. And then ambulation is resumed on the first post-operative day if the patient is, the procedure is done under local anesthesia, and the peripheral examination of the pulse should be done at regular intervals. What are the complications? So the Evar complications include cardiac, pulmonary, renal insufficiency, contrast-induced nephropathy, deep vein thrombosis, pulmonary embolism, coagulopathy, bowel ischemia and spinal cord ischemia. The device migration is obviously when there is an inadequate seal. So when there is a movement of device movement of more than 10 millimeters relative to the anatomical landmark with the use of 3D CT, then you need to look for signs of migration, symptoms of migration. Multifactorial aortic neck length, angulation, non-parallel aortic neck, thrombus in the aortic neck. Short neck and late neck dilatation after Evar is a major cause of concern because of potential loss of proximal fixation and seal. And the complications are, it can result in endoleak, aortic expansion and rupture. So you need to have a strict post-op surveillance. 30 days, you need to go for a CT angio, you go for 6 months, 1 year, and if there is no endoleak, then every year you can go for a contrast ultrasound if it's available, or you may go for a CT at 1 to 3 years depending upon the patient's preference. Thank you.